Hello students, today we are going to discuss a new topic, rectal prolapse. Okay, so what is prolapse? It's something comes out from the body cavity, isn't it? In this case, it's either the rectal mucosa comes out, then we call it partial rectal prolapse, when only mucosa comes out. When full thickness rectal wall comes out, we call it complete rectal prolapse or procidential. Okay. So, who gets rectal prolapse? Mostly it occurs in infant, in children, and in elderly population. Okay, infants. Why does it occur in infancy? In infancy, sacrum is not well developed. The curve of the sacrum is not developed, so rectum has a direct downward descent, and it is more prone to prolapse. Okay, but as the child grows, it recovers on its own. Why it occurs in children? In children, you see what happens if there were episodes of diarrhea because of infectious disease, or they are suffering from malnutrition. In that case, the rectal support, which occurs because of the fat all around, fat in the ischiorectal fossa, that disappears, and the rectal support becomes weak and rectum comes down. It's usually partial rectal prolapse, that is mucosa comes. Okay. It also in children, some congenital condition like Hirschsprung disease or neurological problems, they predispose to prolapse of rectum as well. Why it occurs in elderly? You see, in elderly, females are more likely to get rectal prolapse than men. Okay, so 5 to 6 times more common in females. Usually the pelvic floor weakness is there because of obstetrical injury, episiotomy and perineal tear or things like that. The support system, pelvic diaphragm becomes weak and prolapse occurs. In men, it's usually because of urethral stricture, in which case patient has to strain. They also strain because of constipation, chronic constipation and all. If you have damaged the sphincter during surgery of fistula in ano or hemorrhoids, then they are also prone to get prolapse rectum. Okay, so in elderly population, it's because of the sphincteric weakness and damage and pelvic floor weakness as well. Okay, so chronic straining because of constipation, urethral stricture, damage of the sphincter by surgery, etc., will lead to prolapse. So these are the causes of prolapse rectum. Okay, types I told you, it can be partial rectal prolapse where only mucosa comes, and full thickness rectal prolapse where all the walls of the rectum come out. It's usually more than 4 centimeter. Okay, you see here, this is a full thickness. You focus here, full thickness rectal prolapse. Full thickness rectal prolapse. Okay. Sometimes in 3rd degree or 4th degree hemorrhoids also there is mucosal prolapse associated with 4th degree hemorrhoid and 3rd degree hemorrhoids. So how will the patient present to you? What will he complain? He will complain that something comes out during defecation, isn't it? And he has to push it up. He can also complain of bleeding, that mucosa becomes ulcerated and bleeding occurs. This mucosa becomes inflamed and mucus discharge can occur. And when sphincter is lax, patient can have incontinence. Okay, so patient can present to you with something coming out, bleeding per rectum, mucus discharge, fecal incontinence. Sometimes this prolapse is so much that it becomes incarcerated and it's difficult to reduce. So it can become even strangulated. Strangulation can occur of the prolapsed rectum as well. So this is how they will present to you. So how do you diagnose prolapsed rectum? Obviously you will have to do a clinical examination, put a patient in left rectal position, ask him to strain, do a Valsalva maneuver, strain against closed glottis, and the mucosa will prolapse, will come out like this. Okay. So then you know, or you can ask the patient to sit, squat on the commode and strain, and then you can see whether prolapse is there or not. Okay. See, this prolapse basically starts as an internal intersusception. Rectum intersuscepts on itself, more so on the anterior wall because it is weakest anteriorly, and then slowly it descends down and comes out. So in early stage, when it is only an internal intersusception, will not see anything clinically. In that case, you will have to do investigation like video difficography. Video difficography is a special a special test where we monitor the patient, the process of defecation. Okay, radio level barium paste is instilled inside the rectum. Patient sits on a special commode and his whole defecation process is recorded, and you can see the prolapse of the mucosa and all, and then you know that there is internal intersusception of the rectal wall. Okay. So this is about prolapse. Then how do we manage rectal prolapse? What will we do? See, in infant and children, it's usually conservative treatment or 5% phenol injection in almond oil submucosally will produce fibrosis and can lead to cure of the disease. In adult, you have to do some sort of surgical procedure. The surgical procedure is divided into two things. One is abdominal operation, another is perineal operation. Okay, so perineal operation we do from the below, from the perineal root. The advantages of perineal operation is it's a bit safer in elderly. You can do it under regional anesthesia, and another thing is the patient is frail and elderly, it can be safer. And also you see during abdominal procedure, when you mobilize rectum, there's autonomic nerves there which can get damaged and which can result in sexual dysfunction. So young adults also sometimes perineal approach will be safer as compared to abdominal approach. So what are perineal approach we do? Operations are simplest is encircling of the reducing the prolapse and then encircling the anal canal with either steel or nylon or elastic wire. Put a finger in and tighten it loosely so that it holds the prolapse inside. This is called Thier's operation. Thiersch. Thier's operation. It's more or less obsolete. It's done only for very frail patients. Then another is Delorme procedure. Delorme. Delorme procedure. What we do? You see here. Focus here. The patient is put in the lithotomy position. The prolapse is completely taken out, and then what we do, we give a circumferential incision just above dentate line and resect the mucosa submucosa till the tip of the apex. Okay, see the mucosa submucosa circumferentially has been taken till the tip. Now you plicate the muscle. This muscle is multiple absorbable sutures are taken in the muscles, and then it is tied so that concertina or an effect occurs. It bunches here when you tie it down. Then the mucosa is stitched above the dentate line. This is called Delorme procedure. Okay. When we resect the whole thing and anastomosis done, that is rectosigmoidectomy through the perineal route, we call it Altmaier procedure. Altmaier procedure. Okay. So when only mucosa submucosa is resected and muscle is plicated and then the anastomosis is done between mucosa here, it is called Delorme procedure. When you resect it and anastomosis is done, it is called Altmaier procedures. Okay. So what can you do by abdominal route? Abdominal route, the procedure done is, what we do actually, we mobilize the rectum down to the pelvic floor, and then a mesh is put posteriorly, and mesh is stitched to the presacral fascia and to the rectum and to the side walls as well, not anteriorly, and to the side wall. This is called Ripstein procedure. Okay, or simple suture rectopexy. After mobilizing the rectum down to the coccyx, what we do, we take 3 or 4 sutures, bite in the presacral fascia, in the sacrum, behind the rectum, sacrum is there, you take bite in the presacral fascia and then in the muscular layer of the rectum and stitch it. What it does is, it holds the rectum, it suspends the rectum up. Okay, this is called suture rectopexy. Suture rectopexy. When you put a mesh behind, it is called mesh rectopexy. Okay. And if there is very redundant rectosigmoid, we can also do resection of rectosigmoid, then end-to-end anastomosis, and also suture it. This is called resection rectopexy. Resection rectopexy is a bigger procedure, but it's got very low recurrence. Another procedure which is becoming common these days is laparoscopic mesh rectopexy. Laparoscopic mesh rectopexy has got good results. What is done here is rectum is mobilized, you see, and a space is created in female between rectum and posterior vaginal wall, men between rectum and bladder and prostate, and the mesh is stitched anteriorly here. Anterior, one end of the mesh is stitched, you see here, one end of the mesh is stitched to the rectum anteriorly, and the top end of the mesh is stitched to the sacral fascia. Okay, so that it suspends the rectum up. It's sort of a suspension of rectum up. This is called ventral mesh rectopexy, done by laparoscopic method or robotic method. This is ventral mesh rectopexy. See, the very purpose is to mobilize the rectum and fix it somehow to the sacrum, posteriorly or by anteriorly by mesh rectopexy. Okay, this way you prevent the rectum from sliding down or coming down. Okay, this is rectal prolapse. Another small topic is RED, R-E-D, rectal evacuation disorder, also called obstructive defecation syndrome. In this, what happens is, you see, I told you that rectum intercepts on itself. Okay, so when it intercepts, it creates a fold, and patient gets a sensation that they are not able to evacuate rectum properly. Okay, so every time they have to go and they're satisfied that no, they're not been able to evacuate. That's why it's called rectal evacuation disorder. They're usually constipated. In these patients, because of the frequent interception, mucosa gets eroded and an ulcer appears, usually anteriorly, about 8 to 10 centimeters from the anal verge. An anterior ulcer appears, which we call solitary rectal ulcer syndrome. Okay, ulceration occurs in these cases of rectal evacuation disorder. Okay, this patient will also complain to you about constipation, about bleeding sometime from the ulcer or mucus discharge and all. The treatment here is also the symptomatic treatment. Give them laxative, train them not to strain too much, lifestyle modification, and if it doesn't heal by it, then you can either resect the ulcer bearing area, we call it a STAR procedure, S-T-A-R-R, STAR. S is for stapled transanal resection of rectum. In this, with a stapling machine, what we do, we resect the rectum as well as anastomose it. A stapled transanal resection of rectum, STAR procedure. Okay, this not only resects the rectum but also stitches it, and so the redundant mucosa doesn't intercepts or prolapse. This is called a STAR procedure. Or some sort of re-suturing or resuspension of rectum can be done as well in these cases. Okay, so this finishes rectal prolapse and rectal evacuation.